righty. Thanks for allowing me to talk to you guys today. So today I'm going to talk about lymph nodes and how that's changed over the past years. So a little overview on melanoma. You have to have one of these slides in these talks. Melanoma affects a large amount of people in the US. There's about 62,000 cases that were diagnosed in 2008. This has increased, and there was about 8,000 deaths that year. This is increasing more rapidly than any other malignancy. Part of this is due to earlier detection, and part of this is due to sort of our love of sun. The median age of diagnosis usually is later in life, in the 60s. This is usually damage you did when you were younger that you pay for as you get older. And the risk factors, family history, prior melanoma, they are typically having multiple clinically significant atypical moles. There's one genetic syndrome that involves P16, but most of it is just basically your skin. And fair-haired or fair-skinned people, people that are more likely to sunburn are more likely to get melanoma. 5-year survival of it depends a lot on how it presents. So most likely patients present with localized disease and very thin melanomas, less than a millimeter. Survival for that is about 90% or greater. Localized disease, but thicker melanoma, 50 to 90% 5-year survival, depending on your pathology. And then survival decreases if you have lymph node involvement, 20 to 70%. And then obviously distant metastatic disease, the survival is poor. But all this data has sort of changed. Again, this is data back from 2008. This has changed with the advent of immunotherapy and targeted immunotherapy, so the survival is actually much better now. Typically, when you present with a atypical mole, you undergo a biopsy, and usually that's done most likely as a shave biopsy where they take a little margin around it, but sometimes that can be a full thickness biopsy, a punch biopsy. Typically, that's done to make the diagnosis, and then once we make that diagnosis, we sort of stage people. And we'll hear a lot of terms of staging as this talk goes on, but staging is really a process that we do to get a sense of how people are going to do. We want to get a sense of their prognosis. So early stage is stage 0, that's a melanoma in situ. Stage 1 is basically a thin melanoma. Okay, less than a millimeter. We divide that up between stage 1A, which is 0.75 millimeters or less, and non-ulcerated, versus stage 1B. Stage 2 means a thicker melanoma, greater than a millimeter. Stage 3 means that it's spread to the lymph nodes, or it's on its way to going to the lymph nodes, meaning that if it's on your leg, it's sort of in between the site where the melanoma is and the lymph nodes in your groin. That's in transit disease. Stage 4 means that it's spread elsewhere. So typically our treatment for melanoma, once we've done that staging system, is based on that stage. And for early lesions, T1A lesions, we usually just excise those. Okay? Thicker lesions, those usually get a wide local excision and then a sentinel lymph node biopsy. Very thick or ulcerated lesions, those have a higher chance of having disease elsewhere. So typically, we get a PET scan first in those. If there is spread that's present on that PET scan, we usually give them immunotherapy or targeted therapy. If there's no disease, then we do a wide local excision and a sentinel lymph node. Now, importantly, pre-2017, after you get that sentinel lymph node, this was usually how we treated patients. If the sentinel lymph node was negative, then we just follow them either with physical exam or scans. If the sentinel lymph node was positive, we would typically make sure it hadn't spread anywhere else, so we'd get a PET scan. If there was disease elsewhere, then we'd treat you with either immunotherapy or targeted therapy. If there was no disease, then we'd basically remove the rest of the lymph nodes in that area, which is called the completion lymph node dissection, and we talk about giving you targeted therapy or immunotherapy. That was 2017, before then. So since we're talking about lymph nodes, we should basically explain what lymph nodes are. The easiest way to think about it for the layperson is they're filters. So the body sort of leaks fluid everywhere in your body, and your body reabsorbs it through lymphatics, these little vessels shown on the right that run everywhere in your body. and take that fluid back to your circulation through a little duct called the thoracic duct. Lymph nodes are sort of in the path of those vessels, and they act like filters. So you can see here, this is a schematic of a lymph node, and basically there's a lymphatic channel that empties into that lymph node, and then the fluid sort of percolates through it like a coffee filter, and then exits down here. And along the way, antigens, either bacteria or viruses that are caught up in this fluid, get presented to the immune cells in that lymph node, and that's how we learn how to fight infections. That's why every time you get a cold, which is a viral infection of your nose and your upper airways, the lymph nodes in your neck get swollen because they're reacting to that virus. So these lymph nodes are everywhere in your body, but they're organized in sort of basins. There's areas where there's higher concentrations. These tend to be in your groins, in your armpits, in your neck, or your supraclavicular regions above your shoulder. So early on, surgical oncology or cancer surgeons we viewed cancer surgery as treating the lymph nodes. We recognized early that cancers like to spread to lymph nodes, and we thought that if we can catch it in the lymph nodes, sort of catch it as it's spread to the lymph nodes before it's gone elsewhere in the body, we could cure patients. And so we developed operations to remove all these lymph nodes, and we developed even more radical operations to try to get as much of these lymph nodes as we could. That's why back in the 50s they were doing operations like a radical mastectomy to try to get everything they can with the hope that they could get it before it spread anywhere else. As our knowledge on cancer and medicine evolved, we've started to realize that it's not really just a stepwise progression. It's not that you get a cancer, goes to a lymph node, and then it goes everywhere else in your body. Rather, it can spread to multiple places at once. And so lymph nodes really are more of an indicator that you sort of have more aggressive disease rather than a governor, a sort of stopgap in a place that you can catch a cancer before it spreads somewhere else. This was proven by a guy named Bernie Fisher who did these trials that showed that these radical operations really didn't change your survival. Now, to talk about the rest of the data that I'm going to present you, I'm just going to give you a little bit of background and sort of how cancer doctors think. In terms of our treatment strategies in any type of cancer, we sort of divide it up between a local treatment, meaning treating what you see in one spot of the body. And that's either surgery or radiation, either cutting something out that you see or shining a beam of radiation at it. That's a local treatment. Systemic treatment is basically treating something everywhere in your body, not just what you can see, but the stuff that you can't see, the microscopic stuff. And that's either chemotherapy, a poison to kill the cells, immunotherapy, trying to use the immune system to attack those cells, or biologic therapy, trying to use sort of mutations in the cells that affect them. In terms of survival, when we're talking about these studies, there's different types of survival and outcomes that we measure. So I sort of made a table here so you can see what the different survivals are and what the endpoint that they're typically measuring is. So overall survival is easy. That's basically whether or not you're alive or dead at the end of the study. Disease-specific survival is really how the cancer is affecting you, so whether or not you died of that disease. So if you do a trial on melanoma and a lot of your patients are in their 80s or 90s, you really want to know whether or not they're alive or they died from their melanoma, or whether or not they died from a heart attack or something else. So that's disease-specific survival. Recurrence-free survival basically means that you're alive as one condition, and then you're alive without the disease, that it hasn't come back yet. Progression-free survival means that either the disease hasn't come back yet, or if you had it, it hasn't changed, it hasn't grown or spread while you've been on that trial. So importantly, these two are sort of the earliest sort of a survival where you see effects of the treatment that you're giving. Recurrence, when the cancer comes back, is what a recurrence is. So when we think about these trials and our therapies, there's different recurrences that we measure. So local recurrence means that it came back where you removed it. So if I were to excise a melanoma from someone's arm, And a year or two later, it shows up that there's a black spot right in the center of a scar. That's a local recurrence. It came back right where it was excised. Local regional recurrence means either it came back at that site or it came back in the lymph nodes that drain that area, or in transit disease, which means that it's in the skin along the way to the lymph nodes. Distant recurrence basically means that it came back somewhere else in the body, away from that site, so in the liver or the lung, something like that. Importantly, the therapies we give, we tend to think that local therapies really affect local recurrence and local regional recurrence. Systemic therapies really affect distant recurrence. Now, like I said, early on we recognized that cancers like to go to the lymph nodes, and early oncologists recognized that melanoma cancers, a lot of patients came back with cancer in their lymph nodes, and they tried to basically remove this cancer before it came back in the lymph nodes. So they did operations called elective lymph node dissections, and those were typically either an axillary dissection, so if you had a melanoma in your arm or your chest, you would remove the lymph nodes under the armpit, and that's what you're seeing here, all the lymph nodes in this fibrofatty tissue cleared out under the armpit, or inguinal dissections, meaning that they remove the lymph nodes in the groin. And so there were several trials, really rather series, where they basically electively removed these lymph nodes along with removing the primary tumor, and they saw how people did. And in these series, they basically showed there was very little improvement in survival by just electively taking out these lymph nodes. They did show in subgroup analysis, meaning that they looked at smaller portions of those groups, based on individual breakdowns, that there was more of a survival in patients who were younger, who had ulcerated lesions or thicker lesions. That was shown in the intergroup trial. And then in the World Health Organization trial, this one right here, they showed on a subgroup analysis that if you looked at those patients, the ones that benefited were typically the ones that actually had melanoma in those lymph nodes that they took out. If they took out the lymph nodes and they didn't have melanoma in them, there wasn't really a survival benefit. So they started to theorize, well, what if since the ones that are going to benefit are the ones that actually have melanoma in their lymph nodes, how can you identify those patients that are going to benefit? Basically, how can you know ahead of time before you do these big operations whether or not they have the cancer that's going to benefit from this? So we started coming up with the idea of the sentinel lymph node biopsy. And the idea of the sentinel lymph node basically is if you have a primary lesion somewhere on your skin, there's probably 1 or 2 lymphatics that drain that specific area of your skin. And that goes along and it takes it and it stops by 1 lymph node first. That's the sentinel lymph node. And from there it goes to the rest of the lymph nodes in that basin. And so the importance of that sentinel lymph node is sort of the guardian or more of the indicator. If there's no melanoma in this lymph node, there can't be any melanoma in the other lymph nodes. It can't bypass that lymph node. If there is melanoma there, then you have to worry about the rest of the lymph nodes in that draining basin. So we developed a test where you could basically identify that lymph node. And what this picture is showing you basically is you can inject the skin with a dye in that area, and that'll go along and it'll travel up the lymphatics and it'll get caught in whatever lymph node it encounters first. And there's 2 ways to do this. One is you give a protein that's got a little radio tracer in it, and then you can see it with a special camera or a little Geiger counter. And the other is you can inject some blue dye in it, and you can see in this picture the lymph node turns blue, and that's how you identify it. Okay? And so that was the sentinel lymph node biopsy. So we started to wonder if we could use this like we do in breast cancer with melanoma. And so Don Morton in California did this multi-institutional trial called MSLT-I, Melanoma Sentinel Lymph Node Biopsy number 1. And so like I said, the hypothesis of this was that the sentinel lymph node would be highly predictive on how you survived in terms of your melanoma, and that you could identify those patients who were most likely to benefit from completion lymph node dissection. So they randomized patients to one of those 2 groups, either doing a sentinel lymph node biopsy or not, and they designed the trial around the primary endpoint of disease-specific survival, so whether or not you were alive or dead from your melanoma. And the secondary endpoint was disease-free survival, whether or not it came back. They included patients who were more likely to have a positive sentinel lymph node, so thicker melanomas or intermediate thickness melanomas, and they followed them for about 5 years afterwards. And this is this randomization scheme of this trial. I put this up to make sort of one point. They were randomized 2 to 1, so twice as many got sentinel lymph nodes as those that didn't. And if you had a sentinel lymph node biopsy, it was positive, you underwent an immediate completion lymph node dissection. If it was negative, you were observed. If it recurred, then you underwent a delayed completion lymph node dissection as well. If you were in the observation group, the group that didn't get the sentinel lymph node biopsy, you were followed. If it recurred, you underwent a delayed completion lymph node dissection. So importantly, if you think about it, if you're trying to figure out if this test is accurate, the incidence of this, the patients that have this done is the true incidence of those patients that had occult disease that should have been picked up by the sentinel lymph node biopsy. This is just the breakdown of the patients, and as you can see, the 2 groups were pretty much even in terms of how thick they were and whether or not they were ulcerated. And on the right, you can see that those patients that had more positive sentinel lymph nodes were more likely to be thicker or ulcerated, what we suspected. Okay? Now, importantly, in terms of what I was talking about, the true incidence, the group of patients that had positive sentinel lymph nodes was 16%. The group of patients that were observed and then had a lymph node recurrence was 15.6%. So it tells you that the test is accurate. You're picking out the patients that you're supposed to. There were more recurrences in those that were just observed, okay, which is sort of what you would expect as well. If you're removing the lymph nodes, you're less likely to recur in those lymph nodes. And so the 5-year disease-free survival was higher for those who had sentinel lymph node biopsies versus those that were just observed. But that didn't affect melanoma-specific survival, okay? So there was no difference in whether or not you died of the disease or not, because this is a local therapy, and we'll talk about that more later. And importantly, in terms of predicting how you do with your melanoma, the sentinel lymph node biopsy, whether or not you had melanoma in your lymph node, was the most important predictor of how you would do, okay? Followed by how thick the melanoma was, and then whether or not it was ulcerated. Now, one of the most controversial things about this trial, sorry, I got to go back, was in terms of analyzing whether or not you needed that completion lymph node dissection. So if you go back to that randomization screen, all right, they picked 2 groups. Group 1 was those that had positive sentinel lymph nodes and then underwent a completion lymph node dissection. Group 3 was those that you watched, and then when they recurred, you removed the lymph nodes. So the question is, does it help to get rid of this microscopic disease before it becomes noticeable and you do the delayed function, group 1 and group 3? When they did a subgroup analysis, so they looked at those 2 groups specifically, the survival in those groups that you did the sentinel lymph node biopsy on, the completion lymph node dissection, was much higher than the survival in those that you didn't, down here, 72% versus 50%, okay? Implying that if you catch the disease with the sentinel lymph node biopsy early and then remove the rest of the lymph nodes, you'll do better. The problem with that is it's a subgroup analysis. So you can't really draw conclusions from that because it's not really randomized to look at that question. There's biases in that you can't pick out. So MSLT-I, basically the 2 big points we get from it is that it confirms the prognostic role of sentinel lymph node biopsy, that it's really predictive of how you're going to do, and it confirms that your sentinel lymph node biopsy is accurate. The same incidence of positive sentinel lymph nodes is the same incidence of the people that recurred. So after this trial, up until 2017, the algorithm was typically do a sentinel lymph node biopsy. If it's positive, do a completion lymph node dissection and then discuss whether or not you want to give adjuvant therapy. If it's negative, you just observe the patient and you don't have to do anything else. But, we talked about the lymph node dissections. There's problems with doing this operation, this completion lymph node dissection. It's not a benign operation. The main complications you get from this operation are wound infections and lymphedema. Lymphedema first is swelling. So if you take out the lymph nodes, that fluid sort of has to find detours to get around, and it may be like traffic, it sort of backs up. So the rate of swelling after an operation can be reported to be as high as 25% in some of those old series. Now, not all of that is bad swelling. Most of the lymphedema is pretty mild, just a little swelling, but some patients get really severe debilitating lymphedema. And then wound infections. Did I do that or did you guys do that? Wound infections, these are typically mainly seen in the groin. And these can be bad wound infections that require flaps and plastic surgery to fix. So people started to wonder, do you really need to do those lymph node dissections? Are you really benefiting the patient? There were a lot of retrospective series, and by retrospective series, what I mean is surgeons keep track of a big databases of all the patients they've treated, and then they look back and they try to draw conclusions from those databases. They're not randomized controlled trials, so they can't really show you whether or not there's an actual benefit of your therapy because you can't remove the biases from them. So this is one series that I presented, but there's a lot of other series just like this. This was from Memorial. They looked at 500 patients who had a positive sentinel lymph node biopsy. 2/3 of them underwent a completion lymph node dissection, and 1/3 of them were just observed. These were different groups, though. Like I said, there's biases in these series. There was no difference in terms of melanoma predictors, so the depth and the ulceration were similar in both groups. But in terms of the patients, you can see that there's selections. Those patients that were just observed tended to be older, and they tended to be more in the lower extremity, meaning that we don't like getting those wound infections and the lymphedema, so we're less inclined to do those. So they're not exactly equal groups. The median follow-up was also different. It was higher in the completion lymph node dissection, 80 months, versus 2 years in the observation group. And that could either be just because they started doing it later, or that the patients are older and they're dying before you could see their melanoma comes back. But what they found basically in their series, that there's obviously a higher rate of the melanoma coming back in those lymph nodes if you don't do the completion lymph node dissection. 6% versus 15%. And your recurrence-free survival is better if you do the completion lymph node dissection, 34 months versus 2 months. But there's no difference in overall survival because, again, this is a local therapy. It's not a systemic therapy. But in the observation group, their median survival wasn't met yet because the follow-up was so short. So recently, over the past 2 years now, there's been 2 trials, randomized controlled trials, where we basically did the gold standard to look at whether or not this would benefit patients that were published. There's the DeCOG-SLT trial, and then there's the follow-up to MSLT-I, which is MSLT-II. So the DeCOG trial was basically, they took 500 patients and they randomized them to nodal observation or completion lymph node dissection, 500 patients that had positive sentinel lymph node biopsies. This was done exclusively in Germany, 41 German centers, and it was only trunk and extremities. They excluded head and neck melanoma. Median follow-up was only 3 years, though. Now, importantly, I put this up just so you can, to make a point later, so you can see how these trials work. How they typically work is you screen a bunch of patients, you identify those patients that have positive sentinel lymph nodes, and then a bunch of those patients get excluded for various reasons. Then you randomly assign them, of those patients that are going to be included in your study, to the 2 treatment groups. And then that's basically your intent to treat, those patients that you're intending to treat. Some of those patients drop out and don't actually get the treatment, so you can have 2 analyses. Either an intent to treat analysis where you're looking at those two groups based on all of those you intended to treat, or an analysis on those patients that you actually treated. What this trial showed was that there was no difference in overall survival. So whether or not you lived or died based on whether or not you did a completion lymph node dissection, it didn't affect your survival. There was a difference in improving the local regional control and whether or not it came back in the lymph nodes. 15% in the observation group came back in the lymph nodes, 8% in the completion lymph node dissection group. So again, it's a local therapy. It's affecting whether or not it comes back locally. There were some problems with this trial, though. It closed early, and when we talk about trials, the trials are designed to accrue or collect a number of patients that are based on statistics, so they can show you statistically that the point they're making is there. So they design these trials to get 4,000 patients or so. And then the trials open and they start to collect those patients. Now, unfortunately, if a trial's taking forever to collect those patients, they may stop the trial early and then do the analysis. The problem is that they don't have enough patients, enough numbers to truly make the statistical comparison they set out to do. So this trial closed early because it just wasn't collecting enough patients to it. Also, the endpoint, the expected endpoint, whether or not you had died from your melanoma, was lower than they expected, which means that, again, they actually needed more patients than they had actually designed the trial to accrue. Also, there's a selection bias in this trial. Remember that picture I showed you, and I said that there's a bunch of patients that were excluded from this trial before they were randomized? Those patients tended to be older patients, and they tended to have more metastases in them. So the guys who were designing this trial tended to think ahead of time and say, I don't want to include these patients in my trial, and they're changing the makeup of that trial already a priori, which means that the statistics may actually not be showing what you want them to show. There's a bias in there. Now, the MSLT-II trial was actually a little bit more cleaner and better. This had an accrual goal of 4,200 patients. It began accruing in 2004. The results were published in 2017, so it took 13 years to get this trial. They did not reach their accrual goal as well. They collected about 2,000 patients. This was done in 30 countries. The U.S. made up most of it. They did melanomas that were greater than 1.2 millimeters, so intermediate to thick melanomas. And they did this randomization scheme where they double randomized. So they included patients who had sentinel lymph node biopsies that were positive, but there's two ways they included them. One is when you do the sentinel lymph node biopsy, you have the pathologist look at it under the microscope, and you see if he can see gross melanoma cells. That's the typical positive sentinel lymph node biopsy. The other way you can look for if it's positive or not is whether or not it has PCR positivity. Now, PCR means basically they're measuring DNA in it. So they're seeing if there's melanoma positive by not if they see it, but if there's melanoma DNA in that lymph node. So what that's telling you basically is there's just maybe 1 or 2 cells in that lymph node. They can't really see it. So it's a smaller volume of disease in that lymph node. So both of those were included and they were randomized. And you can see they had about 2,000 patients. Importantly, most of these patients in both of those groups were the traditional, the microscopic positive melanoma, not the PCR positive melanoma. The take-home points from this trial, again, they show no difference in melanoma-specific survival, just like the DeCOG trial. As you can see over here on the right, the curves are pretty much line up for both groups, and then whether or not it was detected by PCR or by just a regular pathology. There was an improvement in disease-free survival, though, whether or not it came back, though. As you can see, these curves separate now nicely. But this was mainly due to nodal recurrence, so whether or not it came back in the lymph node basin that you were removing. And that's expected, right? If you remove all of the lymph nodes in that basin, it can't come back there, right? So that's the take-home point from it, that it improved your local control, but it didn't improve your overall survival. They did find that there's a high rate of lymphedema if you do these dissections. The lymphedema rate was 24% in the completion lymph node dissection versus 6% in the observation group. Now, importantly, though, this was mainly in the lower extremity. The lower extremity we've always known is much more likely to get lymphedema than the upper extremity. Okay? So the real question, when you think about these trials, right, you've got two trials that have shown you that you're affecting whether or not the cancer comes back, whether or not it comes back in the lymph nodes. But you're not seeing a benefit in survival, whether or not you died of the cancer. So why is that? It comes down really to statistics and sort of how cancer behaves. So if you think about it, if you have 100 patients that are positive sentinel lymph nodes, right? How are those patients going to do? The vast majority of them are actually never going to recur no matter what you do. That's the thing that a lot of you guys have realized, that even though it's in your lymph nodes, it's still a very curable disease. And a lot of you patients will do fine even though it's spread to your lymph nodes. So 80 of those 100 patients will never recur no matter what we do to them. 10 of those patients, and these are numbers that you can play around with based on whatever study you look at, 10 of those patients will come back, but when it comes back, it's going to come back in the lungs or the liver, distant recurrence. Those are patients that no matter what you did in their groins or their armpits, it was still going to come back no matter what. 5 of those patients will come back in their lymph nodes and elsewhere at the same time. So a distant and a local recurrence. And 5 of those patients maybe will come back only in their lymph nodes. Right? So if you think about it, this therapy, doing a completion lymph node dissection and treating those lymph nodes, the only patients you're going to benefit from this therapy is these 5 patients down here. The rest of these patients, completion lymph node dissection wasn't going to change anything that happened with them. If they were going to live, they were going to live no matter what you did. And if they was going to come back, it was going to come back distantly and no matter what you did as well. So if you got of those 100 patients, only 5 of them benefited them. If you do a big trial like that with the statistics, these 5 patients get washed out in that survival statistics, and it's hard to see. And additionally, these 5 patients, they're going to die much later than these patients are. So you need a long follow-up to really catch those patients. And we saw this in breast cancer. So in breast cancer, there's been tons and tons of trials in breast cancer, lots and lots of patients that have been followed because it's a very common cancer and it's a very popular cancer to study. There's a lot of research dollars for it. But there was a meta-analysis called the Early Breast Cancer Trialist Collaborative Group. So they looked at 72,000 patients that had either breast-conserving surgery with radiation or just breast-conserving surgery alone. So a local therapy for breast cancer was what they were studying. And they found that at 20 years of follow-up, if you had a difference in local recurrence at 5 years of 20%, at 20 years later, 5% of those patients were alive that wouldn't have been alive. So they came up with this 4-to-1 rule that if you save 4 local recurrences at 5 years, at 20 years, you'll save 1 life. And so that's why these trials, with the 3 to 5 year follow-up that we have with both of these trials, and so few patients, thousands of patients as opposed to 72,000 patients, you're maybe not seeing this survival benefit yet. We know we're affecting the local recurrence rate, but we don't know if we're affecting the survival. And we may be affecting the survival. We just can't pluck it out yet with the statistics we have, with the small size and the small follow-up. So to sort of sum up completion lymph node dissections, what we do know is that it improves local regional control. Overall survival, the early results show that it doesn't improve it yet, but the long-term follow-up isn't available. We have no idea how completion lymph node dissection is affected by the age now of immunotherapy and targeted therapy. We just don't have the long-term benefits or long-term data of how immunotherapy and targeted therapy are even shrinking that number of from 5 maybe down to 1 patient that you might affect. We do know that there is a lymphedema rate, but this is mainly in the lower extremities more than the upper extremities. So what are the guidelines now after 2017? This is the consensus statement by ASCO, the American Society of Clinical Oncology, and by the SSO, the Surgical Society of Surgical Oncology, the 2 big cancer societies. And you can basically see they hedge their bets. They basically say it's up to you what you want to do. Completion lymph node dissection or careful observation are options. No guideline there for patients with low-risk micrometastatic disease with due consideration of clinical pathologic factors. They're basically saying you can do either. For higher-risk patients, careful observation may be considered only after a thorough discussion with patients about the potential risks and benefits of undergoing completion lymph node dissection. So there, you can get the sense that for higher risk patients, they're leaning to doing the completion lymph node dissection, but they're still saying it's an option to either observe or do it. I will tell you what our algorithm has basically been, and this is what we feel based on what we've looked at in terms of the data and our experience with patients. We tend to basically divide it up into where you recur and what kind of health you're in. So if you have a positive sentinel lymph node biopsy and it's in the inguinal lymph nodes, we know the morbidity is much higher. So we tend to favor more doing nodal observation. We will offer the completion lymph node dissection, but we really lean more to observing patients who have lower extremity melanomas nowadays after we have this data. And if you have an axillary one, we tend to favor more doing the axillary lymph node dissection because the morbidity is less. But if you're older and you're sicker, we tend to observe those more. If you're younger and healthier, we tend to do the completion lymph node dissection. And this was just published as an abstract. The actual paper isn't back yet. But this is a review of the National Cancer Database. So the National Cancer Database is a database that collects data from patients of any hospital that's accredited by the American College of Surgeons Commission on Cancer. And they looked at 7,200 patients who had positive sentinel lymph nodes to try to figure out what the practices across the U.S. were. And it sort of mirrors what we do. The completion lymph node rate was performed in about 57% of patients, and they showed that those that were getting observed tended to be more lower extremity, older patients, patients with comorbidities, or patients that were diagnosed after 2015, meaning that now that we have this data, we're tending to share more away towards doing less completion lymph node dissections. So to summarize it up, final points. Sentinel lymph node biopsy is the strongest predictor in terms of survival. Elective lymph node dissection does not improve survival. Completion lymph node dissection improves local regional control. We know that, but we don't know if it's affecting survival.